Hi, everyone. Hello, everyone. Welcome to today's webinar, Recruiting and Retaining Great Members for PFACs. This is part of our Get a Black Belt in PFAC series, where we explore different strategies to help hospitals either start PFACs or to strengthen them. The name actually is based on my black belt in karate and the name of two books that I've written, one of which is Get a Black Belt in Marketing, which is on Amazon. And that was when I was in corporate America. So really not applicable to what we're discussing today. And let me just advance the slides here. So I'm Barbara Lewis, and I've spent more than a decade researching PFACs, culminating in a national mixed methods study on PFACs across U.S. hospitals. My work focuses on helping health systems translate evidence into practical strategies that strengthen patient engagement, safety, and experience. My interest in PFACs began about 12 years ago when I spent 2 weeks in the ICU with my sister, who passed away very tragically. And since then, I've devoted my research and my consulting to helping hospital partner with patients and families and to improve care delivery and outcomes. And I'll be sharing some of that research with you today. So please put your questions into the Q&A and not the chat. And if you don't see the Q&A in your menu in the bottom or the top, wherever it might be floating, click on More, and there you'll find Q&A. So I'm going to be monitoring the Q&A and not the chat. So please put your questions in there. So recruitment remains one of the biggest challenges that I've come across in my research and in talking to many hospitals at conferences across the country, actually around the world. It is a challenge to recruit, and that's why I wanted to have one of the first webinars that I'm doing after I completed my research.
No, it was the very
I need to mute somebody here. And so that is important, I think, to have this webinar. But what I'd like to do today is, before we start with the questions, just introduce our four great panelists that we have. And these panelists are people with whom I've spoken over the years and that I've identified as really having solved the conundrum of recruiting. So Lori Albers is Family Engagement Specialist at Children's Wisconsin. She coordinates 9 PFACs and works closely with families and hospital leaders to ensure representation across multiple service lines. And one of the upcoming webinars that I plan to have is, how do you manage so many PFACs with a skeleton crew of people who are working on them? I interviewed one hospital that had 30 PFACs, a standalone hospital with 30, and it was fascinating what they do. Miss Michelle Fritsch is a project coordinator at Texas Children's Hospital, and she helps coordinate several PFACs, including a dedicated council in the Cancer and Hematology Center. And you can see our first two panelists here are from children's hospitals, and whereas the number of PFACs in U.S. hospitals are about 54%, in children's hospitals, they are 75% of hospitals have PFACs. So children's hospitals are really leading the way. Susan Edgman-Levitin is Executive Director of the John D. Stokel Center for Primary Care Innovation at Massachusetts General Hospital. She's a pioneer in patient and family-centered care, and she helped design some of the nation's earliest PFAC models. Her decades of leadership at Mass General have shaped national policy and inspired hospitals to make patients true partners in improvement efforts. And Terrell Smith is a former Senior Director of Patient and Family Engagement at Vanderbilt University Medical Center. She coordinated 6 hospital-level PFACs, an online asynchronous council with over 8,000 members, and 10 diagnostic-specific advisory groups. And we're going to be talking about the e-advisors which don't actually show up but get surveys, and they are making a tremendous impact on hospitals. So not only PFACs, but also e-advisors. Think about that in terms of getting feedback. So we'll hear from the panelists, and I'm going to share research from my dissertation on PFACs, and let's look at what I have done. So I just got my PhD, crazy, went back to school and late in life to get a PhD, and I did 3 studies. One was a literature review, which has been published, and that was reviewing 143 articles that talked about PFACs and what they're doing. Then a qualitative study, which has also been published, and there I interviewed 20 US hospitals about their PFACs. And the quantitative study, I surveyed hundreds of people, 220 responded to the survey, people who worked for US hospitals around PFACs, and that's been conditionally accepted for publication. So the first question is about demographics, and this is an issue that many people have had. And let's take a look at what the research shows on that. So how well do the demographics of your PFAC match the hospital's demographic? And you see that the excellent match down here is only 3%, and that quite a few, we have almost 50% are a poor match or only a fair match. So let's talk about that then and start off with our questions. So to our panel, how do you determine your PFACs makeup? You know, we're looking at the demographics. How do you get those demographics? So Lori, do you want to jump in and take this one?
Sure. We start by interviewing our vetted families. So we have a pool of families called family partners, and we start there with when it's time to develop a new cohort for our PFAC and kind of cast the net there. We look at a lot of different things for our membership, such as location, background, service lines, socioeconomic status, education, and then really do our very best when we have so many candidates apply that we also want to make sure that we're looking at other diversity lens as well. And then as a team, we take those nominations and then write up information on them and then send that to our leadership. So when we look at our PFAC in general, we are looking not only at our families, but the staff that will also be serving to make sure that everything is accounted for through multiple service lines and experiences.
So first you're looking at the demographics and analyzing that, and then you're matching the PFAC members with those demographics, right? Michelle, what about you?
So we have a similar process, a little bit different. We have such a large, we have about 550 newly diagnosed kids with cancer a year at Texas Children's. And so we actually start with our staff. So I ask nursing, child life, social work, the ancillary staff to recommend families. And when I send the email out, I send it with a very particular request. Families that could actively engage. We want families that are of any background, like, right? But we don't just want families that have good things to say about us. We want all the families, right? Now, if security's been called or something where there's a really big red flag, of course, send the name, but give me a little info. So then after that, I'll get hundreds of nominations. So then I'll go to the physicians and I do a full, I do an Excel spreadsheet on every family. So I get the ethnic, the language spoken, the age of the child, the diagnosis of the child, because there's brain tumor, there's leukemia, and those have very different trajectory in terms of the treatment, the disease progression, whatnot. So we want to get a variety in so many different ways, in addition to in terms of their economic background, that kind of thing. So then I send those names to our physicians and ask if there's any red flags for them. For example, if the treatment is going to last much longer, or if they know for certain this child has already relapsed, or there's something medically problematic for them to be able to participate. Some of the kids are in our clinic every single day for 6 weeks on end, things like that, that would be very difficult for a family to actually participate, even though it's virtual.
Mm-hmm.
And then after that, then I go through and I do a selection to make sure that we have all of the different variety encompassed. And I'll invite 50 families to fill 15 spots, because the onboarding process, and we'll talk about that soon, is where you get your hiccup in terms of where we get the problem where they drop off. Does that answer your question? Sorry, I'm
Yes.
talking too much.
Yeah. Yeah. Thank you. And we are going to get into some of those issues as well. So, Terrell, your model is a little bit different. Can you describe how you manage the demographics within a large online community?
Okay, what we do is anybody can join Advise Vanderbilt, and that comes from a message from the Press Ganey surveys. And so we have over 8,500 advisors across 3 states who utilize Vanderbilt. But the nice thing about that is that we've got a pretty exquisite platform that collects a variety of demographics. And so when we look at then recruiting for our councils, so the Advise Vanderbilt is an asynchronous advisory group, and we call it a council. So they think that they are members of a council, but they're asynchronous, and you can answer questions within 2 weeks. At some point in the year, like September, we put out an invitation for them to say, would you like to step up and be more active and have live meetings online with senior leadership? And so we do it based on demographic deficits that we have on the council. And so we can look and see, do we need people who are younger? Do we need some LGBT representatives? Do we need some people from a certain zip code that is underrepresented? And so we target our invitations at that point within the demographics that we need to fill. And we've got hundreds. And let me just say, I see the program manager for Vanderbilt is online, and I would welcome her to jump in, and she manages all these things, but that's been very successful for us.
And how is the onboarding different for online counsel compared to in-person or hybrid counsel, let's say?
So the onboarding for Advise Vanderbilt is just a invitation to say, would you like to participate? Would you like to be an advisor? And you will be getting surveys that are targeted to your interest. So we don't send questionnaires out on post-op prostatectomy to young women. We don't send OBGYN questions that do not pertain to people who are over 75 and male. And so the way we've got our demographics is that you actually get sent surveys that you would be interested in. So that's a really nice feature of the platform we use.
Thank you, Terrell. So let me just mention that in the research that I did, what I found is that 2 hospitals, in using their e-advisors for surveys, had saved $1 million each. And what they had done is that they wanted to know if people in a certain zip code were interested in going to a clinic in that area that the hospital was planning to build.
That was us.
Okay.
That was us.
Okay.
I answered that question.
All right. And so you could tell the story. You decided not to build it. So 2 hospitals saved $1 million each, they told me, and one was you. Okay.
Yeah. We thought it would be great to build one in this new neighborhood called the Gulch that's kind of trendy and upcoming. And so we sent a survey to the people in that zip code, and we found out that they already had an established home in another primary care clinic that was, just a couple of miles from where we were planning to build it. And yes, so we stopped because they all said, no, we like so-and-so and we already go there, and it's in Green Hills close by, no big deal.
Okay. All right. So Susan, how about you? What are you doing to match demographics, or anything to add to what's been said so far? Are you on mute?
No, I'm not. Can you hear me?
Yes.
Yeah, a couple of things. One thing I just want to mention is that one of the things that I think is very, very important for all of us to keep in mind is that a formal patient family advisory council is not the only tool in our toolbox. And that if you really want to get the right people and people that really represent either the conditions or the communities, the backgrounds that we want to hear from, it's actually much easier to get people with targeted outreaches to address a specific problem so they don't have to make a long-term commitment to attend meetings and whatever. And I just think that's very important for us to remember. You can survey people, as you've heard, you can do interviews, you can have one of the things that we do that I think is one of the most important and money saving activities is we have a whole group of patients that sit in our patient family library that have all been trained in plain language, and they review all of our educational materials, our brochures. And when you start doing that, you don't find them in the parking lot garbage can anymore. They have meaning, they have the right content, they're written at the right level. So I just want to share that's important to think about matching the method of engagement to the problem you're trying to solve, and it makes it easier to get much more diverse participants. But we do a lot of the things that you've heard about. Our patient experience vendor is NRC Health, and they have something called Community Insights. And so everybody that fills, I think it's similar to what Terry described, but everybody who fills out a patient experience survey gets asked if they'd like to help us improve. And if they say yes, they go into a database that has over 100,000 people in it. And so you can go into that, say you want to find out more about Black men over the age of 55 that get care in our health centers with hypertension. And you can find them and then target whatever intervention you want to use with them. And then we also have a panel that's more kind of a marketing panel that I think is similar also to what Terry mentioned about the clinic, that are all people that are enrolled in our portal, and they can be surveyed and ask specific questions about service lines or all sorts of things.
Okay, yeah, thank you. So let's move on to how you recruit now. And let me just show the research, and we're going to go back and forth to the research here. And I think you should, yeah, okay. So this was a survey on the question, and this was a question on the survey, I should say. So a lot of people find people through their electronic health records, and these are the popularity of using various techniques. So word of mouth, you see, is the highest number of people who answered the survey, 20%, family feedback, etc. So let's go to the next question. What recruitment methods have worked best for you? And Lori, you want to kick that off again?
Sure. So we also have in asynchronous electronic advisory, we call it our e-advisory team. And we use that as a recruitment method, not just for our PFACs, but for all different methodologies of volunteering within our organization. But it's turned, we just switched over to Press Ganey this year, and it has been a remarkable recruiting tool for our PFACs. And then up until that point, which was just a few months ago, our most effective recruiting strategy was really asking our providers and having them, just like Michelle had mentioned before, we make that ask of our providers of like, is there anybody you would like to recommend? And those have really been very strong candidates. I find that they're actually stronger than we get from our Eve advisory, because there is that personal touch that goes with it, right? The provider talks to the family gets excited because they feel that they've been chosen, and then they really want, our families really want to be able to give back, but they want to do it in a meaningful way. So knowing that they've been noticed and that they're acknowledged really goes a long way in that recruitment. So I find that those are much stronger families that work with us.
And Lori, what prevents a clinician from just asking people who are raving fans, let's say, are they getting a diverse perspective on the hospital, for example?
I find our providers really do work with a vast diversity within the clinic, and they really do provide a lot of families that have different diverse perspectives. I usually tell providers when they're asking, like, how do I recruit for this thing that we want to do in our clinic? I say, well, find those people that are kind of on the fence, or find those people that have seen a gap in care, right? Talk to them, like, because they have really great ideas, especially if they're saying, I see a gap here, or I'm not happy with this, or this could have really been improved. And if they're able to talk with you in a very constructive manner, those are the people that we want, because they're the ones with great ideas. They're the ones that see the bigger picture. And they're the ones that are really excited about making change because they know it's going to affect not only themselves, but for the greater good of the other people that we serve.
Hmm. So, Terrell, you're having success with Press Ganey surveys too, and asking for people to volunteer at the end of the surveys as well.
Yeah, that was a game changer for us. So, but we do it for the e-advisory group. So when we put out the question on Press Ganey, it is to the e-advisory group. And then we recruit for our councils usually within the e-advisory group, because Lori's having great success with the physician nominations. And we did, for a time, we had limited success, and it was like Lori says, they were so pleased that their physician had recognized them and recognized the potential to give that feedback. So when we did get one, they were marvelous. What we tended to find is that we weren't getting the demographic for diversity that we needed with that. And so this way we can look at our e-advisors, and then we can sort of target our invitations to fill those needs.
Mhm.
But Press Ganey, putting it on Press Ganey, Children's Hospital Vanderbilt actually put a notice on on Facebook. And
Oh,
so if your hospital has a Facebook page, Children's recruited like 100 people off of Facebook one year.
oh, wow. Impressive. Okay.
Yeah.
So, Michelle, Susan, anything else to add to that that's different, or should we move on to the next question?
Just one quick oh,
Sure.
sorry,
Go ahead.
Michelle, go ahead. One quick comment that builds on, I think, what we just heard, and that is when we recruit through our clinicians, which we have also found to be really successful, we make it very clear that we're looking for people that have had all sorts of experiences. The only thing we ask is that they be someone that knows how to deliver constructive feedback, and not somebody who's just incredibly angry and only cares about one subject or one type of experience or that sort of thing. And that usually is very helpful guidance.
Mm-hmm. Mm-hmm. And so that actually leads into our next question is what qualities are you looking for? And Susan, do you want to just continue and talk about the different qualities? Because I remember I had a conversation with you and then I
Yeah.
left.
Well, we look for people that know how to deliver constructive feedback, whether it's positive, negative, whatever. We look for people that have had the experience, either a condition experience or an experience trying to use a particular service or whatever that we want to improve. We look for people that are available for the kind of tasks that they might need to be involved in. And I think, and this is where Barbara and I left, we also look for people with a sense of humor, because having a good sense of humor helps all interactions. And I also think it often, in some respects, helps reduce some of the clinician anxiety, because people are often early on very nervous that patients are going to want the sun, the moon, and the stars.
Mhm.
And are they going to be really angry? And they're not. They're very grateful. And they find it, in my experience, fascinating to understand all the rules and challenges that we have to live by that we think are as crazy as they do. So, but we can't change them.
Carol, I think that you had a similar experience. I know that you and I had talked about what you look for and what you don't look for.
Well, we don't look for people who have a lawsuit against us. That's one thing. Um, but Susan's sense of humor piece really resonates because some of our clinicians are kind of hesitant. They're hesitant to come, or they're like, oh, this is a council, and but they do come, and once they realize that these people are really trying to partner with us and they're trying to co-create with us, then it's really a breath of fresh air to come in there and try to hear some of their comments and suggestions. So you do have to have people who can get off of one subject, though,
Yeah.
and see the big picture.
Right. And I just had some research about that, and I will show that just very quickly. So in my research, I found that 3 hospitals actually closed their PFACs because of disruptive members. So, you're looking for someone who doesn't have an axe to grind or who's angry, and is just focused on one issue, as Susan Terrell said. So a candidate interview, and it's amazing. You just in some hospitals, you raise your hand that you want to be on the PFAC, and you're on the PFAC. There's not even an interview. So definitely having an interview, looking for those characteristics, discussing with the patient's doctor, finding out about litigation, and having them attend a trial meeting. So one PFAC, for example, had somebody who was interested in being on the PFAC and just completely monopolized the conversation. So you want to have them in a pre-meeting also to make sure that the interaction is good. And of course, there's documents and norms that people sign as well. And the result is, of course, a productive council. And with regard to attending a council meeting, this was very surprising to me that a little more than a quarter of the hospitals ask a member to attend a meeting before actually being on the PFAC. So I thought that was interesting. Okay, we're going to move on because this time is just flying by here. Okay,
Barbara, can I add one
Yeah,
other thing
yes, go
just
ahead.
quickly?
Sure, yeah.
One of the things that I learned very early on from, I think, the mother of all this work, Bev Johnson, from the Institute for Patient and Family Centered Care, is it's very important if you have a formal PFAC, it's very important to sort of set the time frame for any participation. But for PFACs, we found that it's very important to have terms. And because if you have a 1-year term and you realize somebody's not the right fit, just like on any committee, then you have a diplomatic out to thank someone and their term is over, rather than having uncomfortable conversations when, somebody's not the right fit.
And here's what the research shows that I did. Is there a defined term of membership? Only 2/3 have one. So over 1/3 of hospitals have PFACs where you just get on it and there is no term. The duration of the term, the majority have 60%. But because I've learned about the fact that there's been a number of PFACs that have closed because of disruptive members, I'm saying, you know what, let's do 1 year and then have re-upping 1 year after another for 5 years or however many that you want. But yeah, that's a good point, Susan. Thank you for that. Okay, let's move on then to the next question. What is the most significant aspect of recruiting members? And the challenge, let's say, and how did you address it? So, Lori, do you want to start us off here?
Sure. We really do struggle, I think, like so many PFACs, and so many hospitals out there recruiting, families with diverse backgrounds. And for us, the biggest challenge has been our Black and Arabic communities. Arabic partially because I don't speak Arabic. It's very hard for me to recruit from that population, and we just don't have a very good infrastructure to support that. We're currently recruiting for a brand new Spanish language PFAC, but we do have a number of people within our organization that speak Spanish, and we're able to go into the clinic and to do, provider referrals. And so that's moving slowly, but we're moving in that direction. But with our Arabic population, not so much. And we just don't tend to have a lot of, even though a vast majority of our families, are from the Black African American community, we just don't have that representation very often. The families that we do have are amazing and very engaged, but to bring others along has been a struggle. That is not something we've been able to solve easily. And I'm hoping that will be a target for us for 2026.
Mm-hmm. Okay, anyone want to jump in here and discuss how you have solved the dilemma of finding a specific population that you want on the PFAC?
We just, Houston's just real diverse in general. So and cancer doesn't discriminate. So we've not had any problem finding families from every demographic. We do have a pretty significant Arabic population because they come from overseas, come from Saudi or wherever. So we do have that, but most speak both Arabic and English. We don't have a specific Arabic speaking council, but we are working on a Spanish speaking only council. Quite a few of our members right now speak both Spanish and English. But when visiting with quite a few of the different families, I've found that if they speak Spanish only, they prefer to have a designated counsel for them rather than have someone who translates and goes back and forth. So we have gotten that feedback. But yeah, we've been very fortunate. Our biggest hurdle or barrier has been families that are on government assistance, because unfortunately, with the way our councils operate, the onboarding process is similar for virtual as it is for in person. And so we do a training, they have to do a criminal background check, things like that. And we lose people in that process. So what I did about a month ago is meet with our patient family engagement group who does the onboarding for us to discuss other options, because if they're not coming on site and we don't really need to know if they're vaccinated for measles, if they're virtual. So to see if we can change those rules for the virtual only, which I'm hopeful will get passed, and that will eliminate some of the onboarding barriers.
Mm-hmm. So anybody else dealing with the drop off and when it's occurring in the onboarding process?
We just had trouble with a live on-site monthly Spanish only group. And it really kind of limped along for a couple of years, and the attendance was not good. And we had the same issue with translating back and forth that I think Lori talked about. So we actually just went with our vendor, our Advise Vanderbilt vendor, and we created an pretty much additional expense, a Spanish only Advise Vanderbilt. And that has gotten much more traction. And I think we've got, Lisa may know, but at least 50 members that way who are now participating.
Oh, wow. That's
Yeah.
great.
Say that's actually what we did at Children's as well, as we have our own Spanish language electronic advisory. We have about 25 families in there and are getting 5 to 6 of them consistently, providing us with feedback, which is way more than we had previously.
Yeah.
Yeah, we do have Spanish-speaking advisors that help with like a fact sheet and things like that are basically email versus a virtual meeting once a month kind of thing. So that is for us, that is a very easy lift.
And Barbara, just quickly, one of the things that we found during COVID is that when everything went virtual, we found it was much easier to recruit people from very diverse communities that we serve because they didn't have to, for many people that don't live in Boston, coming to Mass General is kind of like going to South Dakota. And so it's also really challenging because there's a lot of construction around the hospital area now. And so being able to get people involved virtually made a huge difference in terms of the diversity of the people that were interested in participate and able to participate.
Mhm.
Our attendance and our participation went up.
And here's what the research shows about that. So how does your PFAC meet? Hybrid, 57% are now meeting hybrid, where you can either come in person or you can go online, or it's one or the other. Some are hybrid, and then there's one at the end of the year that might be in person, for example. I did find that geriatric councils tended to want to meet in person.
Yeah.
And that may be because of the technology challenge or the socialization, for example. We had the Surgeon General say that loneliness was one of the biggest issues that we're facing, and that tends to be not only with young people these days, which is kind of surprising, but also with older people as well. So the hybrid, you get more demographic representation. And then how often does the PFAC meet? Most meet monthly. This is good. I personally have found that less than monthly, the momentum decreases. And I've been on a number of PFACs, but the ones that meet every other month, I find that the momentum sort of lags here. So let's look at another research question. And that was about how long do the meetings last? So the majority, or a large percentage anyway, is 90 minutes. And the time of day is the afternoon and the PM. And then it's a challenge for the employees to meet after 6 p.m., but this is where you're going to get your demographics probably here as well. So we have a lot of questions in the chat, and I'm going to try to do this as a rapid fire so that we get through them all. And then the last thing that I wanted to discuss was the closing the loop and engaging, keeping the PFAC members engaged. And one of the most important things that I found in research is closing the loop. Okay, Susan, you mentioned training in plain language. Can you drop that resource into the chat or just mention it?
It's just plain language is just a method of how you write materials so that you massively increase their readability and their impact. And I think if you Google plain language training, there are lots of trainings available online.
Okay, thank you. Are you using Press Ganey's Forsta Community Advisor platform? For those of you who are using Press Ganey. No?
We are currently not, but I think we might be thinking about it.
Okay, talking more about e-advisors, I think that did you want to hear more, Carol, about that? Okay, how do you define e-advisors? Simply community members engage only via surveys? Yes, that's it. They're via surveys. They don't attend meetings. What is the split of patient and family members to staff on a good council? So I found that the average number of people is 13 and that the staff is 7. That's what the research actually showed, and I don't have that slide up. Have any members of a PFAC been interviewed by a CMS surveyor or joint commission? Yes. The joint commission comes in and they ask to speak to PFAC members. What about CMS? Do any of you know whether or not CMS comes in and asks to speak to members?
Not to my knowledge.
Okay. And they do have those 5 domains now, CMS, and one of the domains is patient engagement that you have to attest to. So the hospital has to sign off on that. And in the literature about that domain, the documents, I should say, from CMS, they do mention patient and family advisory councils. So, okay, somebody has said here that they reach out to get demographic representation at churches and the NAACP. And okay, please elaborate on e-advisors. So we have lots of interest in e-advisors. What I'm thinking that maybe we should do is I should just have one webinar on e-advisors. So maybe we'll do that. Remember, if you have any questions, put that in the Q&A. And if you have comments and continuing the conversation, that can go in the chat. Okay, let's move on. Oh my gosh, only 5 minutes left. This has gone by so fast. I did a survey actually, and I said, what's the longest that you would like to attend a webinar? And 45 was the winner, 45 minutes. So that's why I decided not to make this 60, but maybe I gotta change that for the next one. So one of the important things that I found, and let me show the next slide on this too, is how frequently, I'm looking at my other monitors so I can share this. How frequently is the department's implementation of PFAC advice shared with the council? So, the best practice is here, but I was really surprised that it was only 20, a little more than a quarter. And that there's a lot down here that are just not sharing the advice. So in one of the conversations that I had, the person who headed the PFAC said that a PFAC member was resigning, and they were so upset because this was a great contributor and really worked well with the PFAC. So they sat down with the member and they said, why are you leaving? And they said, because I give you my advice and I never know what happens to it. And somebody then countered and said to me, well, they can walk around the hospital and they can see what their impact is. And that's not really the best way to be closing the loop with our members on the PFAC who are devoting their time and energy and their brain to come up with feedback for hospital care delivery. The best thing is to let them know what's happening. So let's conclude here with a couple of comments about how are you closing the loop? And Lori, you want to start off?
Sure, I'd be happy to. So at Children's Wisconsin, for our hospital-wide PFAC, we have our presenters come back. So just because they came and presented doesn't mean we don't know what happened to the information and the impact that the feedback had. So we try to bring them back within 6 months. Sometimes it might be a year, it depends on the particular project, but we do have them come back. We really want them to close that loop and be very specific about what did they listen to, how did it impact decision making, what was the impact that it had, and maybe even with the changes, how did that impact care, right? So we do have them come back. We also send out a quarterly newsletter to our family partners. So our family partners are our e-advisors. They are our virtual partners, and they're also our on-site volunteers. So we take all of the different things that have happened during that quarter and have the newsletter really explaining, these are the things that our families got involved with, and this is the impact that it had. And then we do an end of year impact report. So the impact report was initially just written for leadership, but we found that it was really helpful for our families to also see what was the yearly impact. Like, I only come to this one meeting, but we have other councils and other advisory boards. What are they doing, and does it matter? So that impact report goes out to everyone as well.
Great. Yeah, that's great because what I found with closing the loop, that it helps with the engagement and the retention of members too.
Absolutely. When you know that you're listened to and that something that you've provided was really valuable, and then you can see the impact that it's had on care quality and safety, I think it really matters to say it's worth my investment of time to still come back and to give back to the organization.
Right. Yeah. Right.
Can I add something real quick, Barbara?
Sure.
We at Texas Children's also provide that executive summary and the feedback to our medical staff. So we have 140 physicians here, and they all see different populations. They might have a research arm, but we do at they have like a monthly meeting, and we provide a slide every month to give them a report, a brief report about the impact, so that they know what the families have contributed, but also so then that helps them with recruitment, so they have an idea of what the kind of the circle, if you will, to close that loop for them too. But then they can see how the families make an impact, and they also get to see that it really makes a difference to those families. We have so many quotes, and I typically add a quote from a family member about how it was important for them, for their how they made a difference in the life of somebody else from their.
Yeah, and since word of mouth is one of the most prevalent ways to find people, then letting the PFAC members know what they've done, their contribution that's really important. So we're coming up on our conclusion here of the day of this webinar. So let me just tell you that share a quick screen and tell you what the next one is. And these are all based on the most prevalent problems that I found. So how frequently do you provide training for your members? And we have hospitals out there that are, I'm not talking about onboarding or orientation. I'm talking about storytelling, for example, or using metrics, for example, to measure the value. And you can see here that in the survey, only 1% are providing any training for PFAC members. So that'll be the next webinar. And if you received an invitation to this, then if you're here, I should say, I have your email address. However, if you're in a room with several other people, I may not have your email address. And if that's the case, send it to me so I can send you an invitation. And thank you so much to our panelists. I so appreciate it. Lori, Michelle, Susan, and Terrell. This has been absolutely so important and interesting to find out what you're doing, that you have actually solved this conundrum problem of recruiting, and hopefully this will help everybody else as well. Thank you, everyone, for attending, and hopefully I'll see you again soon. Thanks a
Thank
lot.
you.
Thanks so
Bye-bye.
much.
Bye.
Bye.
Bye.